supporting you. We're here to support you. All right, everyone, if you could please take your seats if you're attending the lecture, would appreciate it. Welcome, everyone, to session number 32. The title of this session is Thrombosis Prevention in Valvular Heart Disease. What is the role of direct-acting oral anticoagulants? And our speaker today is Dr. Rachel Ryu. And Dr. Ryu is an assistant professor at Western University of Health Sciences College of Pharmacy. She received her PharmD from the University of Rhode Island College of Pharmacy with a magna cum laude and is a recipient of the University President's Academic Excellence Award. She then completed her ASHP accredited PGY1 pharmacy residency and an ASHP accredited PGY2 cardiology residency at Loma Linda University Medical Center and School of Pharmacy. During her training, she obtained a postgraduate teaching certificate and became board certified pharmacotherapy specialist. Dr. Ryu has experience teaching cardiology and integrated pharmacy practice courses both at Loma Linda University and at Western University, and precepts students in their experiential education. I'm hoping she's going to precept me today. She's currently serves as co-advisor for Western University student chapter of APHA, which is very laudable, and membership committee chair of the Inland Regional Chapter of CSHP, communication liaison of the CSHP New Practitioner Executive Committee. She is passionate about staying involved in pharmacy, a good thing, and giving back to the profession. We hope that you'll continue doing that. Her clinical and research experience lies in heart failure and transplant, cardio-oncology, and antithrombotics. She has published multiple peer-reviewed journals. So please, at this time, join me in welcoming Dr. Rachel Ryu.
Thank you so much, Dr. Kudo, for the very amazing introduction. I'm very humbled because he's been a pioneer in this field for a long time, and the fact that he's here today asking me to precept him, that's very, very humbling. So thank you so much for that. You are too kind. Thank you so much, everyone, for joining us here today. DOACs, as we all know, are a very hot topic. And when we think about DOACs, we always think of DOACs as being indicated only for non-valvular atrial fibrillation, right? So a lot of the times, just the other day, someone said, oh, so what are you presenting on at seminar? I said, oh, DOACs in valvular disease. And then the response was, oh, I thought they're only indicated for non-valvular disease. So my point was proven. So today we're going to explore all the data as far as the safety and efficacy of DOAC usage in valvular disease, which is more and more common nowadays. So it's very clinically relevant during this time. So thank you so much all. Hope you find it very useful and interesting. I do not have any disclosures. Here are all my abbreviations listed here for your reference. Learning objectives are listed here for you. Hopefully you will all be able to accomplish them by the end of the presentation today. Number one, what's the #1 leading cause of valvular disease worldwide, which is very different from here in the United States. As far as considerations, how do we select between a mechanical valve versus bioprosthetic valve? We'll talk all about that today. Mechanistical difference between DOACs and warfarin, pure pharmacology here. And lastly, we have a patient case. It's an AFib patient, status post-TAVI, and what are we going to do as far as antithrombotic regimen? So valvular disease, simply defined, here is just basic review of anatomy from back in pharmacy school. We have the mitral valve, which allows for blood to flow from the left atrium to the left ventricle. And then we have the aortic valve, allowing blood to flow out of the left ventricle through the aorta into the body. And then we also have the pulmonary valve, which returns deoxygenated blood back into the lungs for oxygenation. And lastly, we have our tricuspid valve, which allows blood to flow from the right atrium to the right ventricle. So valves are simply just one-way inlets, allowing blood to flow in, and once the blood flows in, it should close, ideally. So very simple. As you can see in the picture, the valve opens, and then the blood flows. After that, the valve should ideally close all the way, very tightly, so that the blood doesn't flow backward, which is called regurgitation, and we'll talk about that later. So valvular heart disease is simply defined as when any of these 4 valves in the heart has damage or is diseased. So as far as prevalence goes, as you can see, the largest prevalence is in our elderly population. So there does seem to be an independent risk factor with age as far as disease prevalence. Up to 3%, almost 3% of the population in our country does have valvular heart disease. And again, prevalence is highest in our elderly population. Deaths do occur, unfortunately, which is why this is very clinically relevant. Most common complications are due to heart failure. So if the valves are not working properly, the rest of the body does not get enough oxygenation of the blood. And therefore, the heart can compensate by activating our sympathetic nervous system, our renin-angiotensin-aldosterone system, and therefore ultimately causing heart failure. When the blood pools, because the blood doesn't flow properly from one compartment of the heart to another, something called blood stasis or blood pooling can occur. And that can cause complications such as stroke, MI, or venous thromboembolism. And all of those can be fatal. The most commonly affected valves are on the left side just because the shear stress is much higher on the left side. So the mitral and aortic valve, the mitral meaning the left atrium through the left ventricle, that valve, and then from the left ventricle out to the rest of the body is via the aortic valve. And just because the shear stress is significantly higher there, those 2 are the most commonly affected valves. As far as mortality, well, we just said that aortic and mitral are the most commonly affected valves, so it does make sense that the most common deaths are due to the aortic valve. We're going to briefly talk a little bit about what stenosis is versus regurgitation, just to make sure we're all on the same page. So stenosis is when there's narrowing of the valve, thereby restricting blood flow. So we have 2 different types: mitral valve stenosis and aortic valve stenosis. Mitral, remember, left atrium to left ventricle. When that valve gets narrow, there's less blood flow being pushed from the left atrium to the left ventricle. Same idea with aortic stenosis. So when the aortic valve gets stenosed or narrowed over time, there's less blood flow from the left ventricle out through the aorta and into the rest of the circulation. Regurgitation, on the other hand, is when the valve is leaky. So instead of the valve being narrowed or stenosed, it doesn't close properly. So the blood flows backward. So MR, or mitral regurgitation, is when the mitral valve doesn't close all the way, and therefore blood flows backward from the left ventricle into the left left atrium. Thereby, there's ultimately less blood flow out from the left ventricle through the aorta into the rest of the circulation. Same idea with AR, or aortic regurgitation. When the valve doesn't close all the way, the blood flows backward from the aorta into the left ventricle, ultimately causing less blood flow throughout the body. So as far as etiology, we talked a little bit about that earlier. There is a significant difference between what is the #1 cause of valvular disease worldwide versus here. So in the United States, we're very privileged and fortunate to have the right antibiotics and to be able to effectively treat streptococcal infections. However, the rest of the world does not have the same privilege, and therefore untreated streptococcal infections can cause rheumatic disease, causing rheumatic fever. And when that happens, there's inflammation or scarring of the heart, especially the mitral valve. As you can see on the picture, that's what a normal mitral valve looks like. But over time, after rheumatic fever develops and there's inflammation and scarring, the mitral valve can stenose or narrow. The number one cause, in contrast to worldwide, here in the United States, we do a good job of treating streptococcal infections, and we're very lucky to be able to do that. However, over time, I don't know if you remember from previous slides ago, with the increasing prevalence with valvular disease over age, so over time, calcification can occur, meaning there's calcium buildup or accumulation in our valves, and that's what that might look like. And that's just part of the normal aging process. And so here in the United States, the number one cause is not rheumatic disease or rheumatic fever, but it's calcification, just pure calcium accumulation over time. And of course, there's congenital heart valves. For example, there's supposed to be 3 leaflets here, but there's something called bileaflet valve disease when patients are born at birth with only 2 leaflets. And the only management strategy is via surgery or valve replacement. So clinically, patients can have a very wide range of symptoms, or they might not have any symptoms at all, depending on their severity. A lot of the symptoms resemble those of heart failure, right? Because when there's less oxygenation of the blood circulating throughout the body, going to the target organs, in compensation to that, heart failure can develop because your sympathetic nervous system and your renin-angiotensin-aldosterone system get activated. So a lot of these symptoms are very similar to heart failure symptoms. So when there's less oxygenated blood throughout the body, patients may commonly feel fatigued, short of breath. Also, if there's any mismatch between oxygen demand versus supply, that can cause chest pain. So that's also a common symptom as well. However, the definitive way of diagnosing valvular disease is not via clinical presentation because those can be nonspecific, but it's really via TTE or transthoracic echocardiogram. And that's just a non-invasive way to look at the heart. And as you can see in the picture, that's a severe aortic stenosis. And as you can see, the valve has significant calcification there. And it's really the gold standard to look at the valvular morphology and the severity. And typically this is adequate. However, we would proceed with further workup as well. ECG, perhaps the patient was having chest pain because maybe they're having a myocardial infarction or MI. As well as concomitant AFib, which is very common in this population, and we're going to be talking about that a lot today. As well as further testing. So if patients present with shortness of breath or dyspnea, there can be underlying causes, other causes of that presentation, such as pulmonary infection, right? So we would treat for that underlying disease. And they might have pleural effusions or pulmonary edema that can also commonly cause shortness of breath. So we would just rule out other causes of dyspnea here. TEE is just is transesophageal echocardiogram. It's a more invasive way compared to the TTE of visualizing the heart. Typically, TTE itself is adequate. So we wouldn't necessarily need to proceed with more invasive tests. As far as staging goes, it's really based on objective criteria, such as mean gradients, valve area, how much of the valve is stenosed, how much of the blood is being regurgitated back into the previous compartment. So it's really based on objective symptoms, but ACCHA further classifies into asymptomatic, symptomatic, etc. And as far as intervention goes, for surgery or any transcatheter interventions, that's really reserved for patients with moderate to severe valvular disease. And again, that's based on objective criteria. So just this slide and the next slide are just a brief timeline of all the management strategies that are available to us for valvular disease. The first one is on aortic stenosis or aortic regurgitation. Here, also called SAVR, surgical aortic valve surgery or valve replacement. This was always the gold standard for symptomatic severe aortic stenosis. It's highly invasive. It's essentially an open heart surgery to take out the diseased valve or the old valve and replace with either a mechanical or bioprosthetic valve. And we'll keep coming back to mechanical and bioprosthetic valves. So this is really the gold, it was traditionally always the gold standard. BAV, or balloon aortic valvuloplasty, is just a temporary fix. So it's non-invasive. The surgeon usually goes in through the femoral artery, puts in a catheter and gets a balloon to inflate the stenosed valve. After that, they just take out the catheter. So nothing is permanent, it's very temporary. It's just a bridge to either SAVR, which is a surgical aortic valve replacement, or this next one, which is called TAVI, or transcatheter aortic valve implantation. So some of you guys might have heard TAVR being used. In the literature, both terminologies are used. However, the more accepted terminology nowadays is transcatheter aortic valve implantation, because in contrast to TAVR, we're not replacing anything. We're keeping the old valve in. So as you can see here, this is also non-invasive. The surgeons go in through the femoral artery, keeping the old valve in. They just implant a new bioprosthetic valve. So we're keeping the old valve in here. And so TAVR was a little bit misleading because we're not replacing any old valves here. We're just implanting a new one on top of the patient's old diseased valve. And so this kind of changed everything. SAVR used to be the gold standard until TAVI came into the picture. So initially when TAVI got approved, it was only reserved for patients who couldn't withstand surgery. So patients who were at high risk of bleeding, or elderly, frail, patients who were not able to go through surgery. So high-risk surgical patients only. However, just 2 years ago, there's an approval for patients even with low surgical risk. This is actually indicated, and that's okay, and it's being commonly done nowadays. So the most common and more definitive measures of managing aortic stenosis or aortic regurgitation is SAVR or TAVI. SAVR, again, we could use either mechanical or bioprosthetic valve. TAVI is only bioprosthetic valves. There's no available TAVIs that come in mechanical valves, only bioprosthetic. And we'll keep coming back to that because all of that's going to determine antithrombotic therapy. As far as MS and MR, just very briefly, mitral valve replacement was the gold standard and still is the gold standard. We don't have anything like TAVI with strong evidence for mitral valvular disease. So mitral valve replacement, again, this is like similar to SAVR. It's an open heart surgery, highly invasive, and patients can either get a bioprosthetic valve or a mechanical valve. Again, percutaneous balloon valvuloplasty, again, is very temporary. It's only a bridge to either a valvular replacement or, I guess here, just the replacement, not TAVI. Again, the surgeon goes in through the femoral artery, gets a catheter, gets a balloon, inflates it to open up the narrowed valve, and then takes out the catheter. So again, as you can imagine, the valve would restenose over time, and that occurs pretty frequently. Alfieri stitch, this is just a quick repair. Dr. Alfieri, he was an Italian cardiac surgeon, and he came up with this edge-to-edge repair, which is very effective for mitral valves. And then there's this mitral clip, also kind of pretty cool. It's a very non-invasive way of going in through the femoral artery, and then where the valve is keep getting regurgitated, or where the blood is keep flowing backward because the valve doesn't close all the way, at the end there's a little clip to hold down the valve that keeps flopping open. So usually patients get dual antiplatelet therapy for a little bit, like 1 month, and then aspirin monotherapy thereafter. But this is, it's really reserved for patients who can't withstand surgery. So again, for mitral valves, surgical replacement is the gold standard. So these two are going to be the most common strategies in clinical practice. So we mentioned mechanical versus bioprosthetic multiple times. So what are they? So mechanical is made of metal and plastic. So as you can imagine, it has a very high risk for thrombogenicity, and therefore requires lifelong anticoagulation, specifically with warfarin only, not DOACs, and we'll go into the studies for that later. Bioprosthetic heart valves are, in contrast to being made of metal and plastic, are made of either cow or pig tissue, and therefore there is a significantly lower risk for thrombogenicity. And as far as antithrombotics go, generally, only a single antiplatelet therapy regimen is required. And I say generally because all of that's going to change if a patient does have, for example, AFib or another concurrent indication for anticoagulation. So in general, if patients are getting TAVI only, they would only qualify for a single antiplatelet therapy. Just a brief review of pharmacology. Mechanical valves tend to cause more clotting via the tissue factor pathway, which is factor 7. And as you might remember from pharmacy school or basic pharmacology, warfarin inhibits factors 2, 7, 9, 10, C, and S, protein C and S, which is much more than what the DOACs inhibit, right? Because the DOACs, except for dabigatran, which is a direct thrombin inhibitor, factor 2, the other ones, apixaban, edoxaban, and rivaroxaban, are 10A inhibitors, and those are outside of the tissue factor pathway. So warfarin inhibits more factors generally. And as far as platelet versus coagulation cascade, we do see mixtures of both coming into play. For example, in acute MI or acute myocardial infarction, we have both activation of the platelet cascade as well as the coagulation cascade, which is why in the hospital setting we do want to give high-dose aspirin, 162 to 325 milligrams as soon as possible, and start heparin, give a bolus, continuous infusion. So both come into play here. And just a brief review that the DOACs, except for dabigatran, are 10A inhibitors, dabigatran being a direct thrombin inhibitor, and then aspirin and clopidogrel are antiplatelets. So they work in separate systems. So kind of shifting gears a bit, how do we select between a mechanical or a bioprosthetic heart valve? So we said mechanical is made of metal and plastic, bioprosthetic from cow or pig tissue. So how do we select between the two? So I really like this study. This was a randomized study of 13 VA hospitals or centers. And it was 575 patients receiving either aortic valve replacement or mitral valve replacement. They were randomized to either bioprosthetic or mechanical valve. And what they found was very interesting. At 15 years, there was a significant reduction in all-cause mortality for patients who got a mechanical valve compared to bioprosthetic. This is only found in the statistical significance was actually only found in aortic valves, however, but it's kind of being translated for mitral valves as well. In addition to the significant reduction in all-cause mortality, we found a significant reduction in primary valve failure rates. So because the mechanical valves were more durable and lasting longer, perhaps patients, that's why they were living longer. But there's a caveat here because we said mechanical valves, patients require anticoagulation, unlike bioprosthetics. So of course, reoperation risk, because the valve was failing more, of course the bioprosthetic heart valve patients had to get reoperated. But back to mechanical heart valves, patients requiring anticoagulation, specifically with warfarin, because of that, even though they were more durable, patients were living longer, there's a lower valve failure rate. Patients had a much higher bleeding rate for mechanical valves. So kind of piecing all of that together is how we will determine which valve to use. So considering all of that, mechanical valves are preferred in patients who are younger, because, right, if they're younger, the valves are going to last them a longer time, and we're able to justify it. And remember, mechanical valves require anticoagulation, specifically with warfarin, so patients have to have an acceptable risk of bleeding. And concurrent indication for anticoagulation, you're probably going to hear me say this like 20 more times today. So if patients already have a baseline indication such as AFib and they're getting a valvular replacement, if they're already on, for example, rivaroxaban for AFib, and that means they're already on anticoagulation, right? So might as well keep them on. That's the logic here. Versus bioprosthetics are preferred if patients are older, right? Because older patients tend to have a higher bleeding risk. And even though the valve itself might not last longer, right, as compared to mechanical valves, even though it's not going to last them longer, it's going to last up to at least 15 years based on the study that we just talked about. And they don't have to be put on anticoagulation. So that's why for our elderly patients, bioprosthetics are preferred. Of course, if patients have a high risk of bleeding, if they're younger, but they tend to have some kind of a genetic disease, or they have to be on high-dose steroids for immunosuppression, if they have a baseline high risk of bleeding, then in that case, even though they're young, bioprosthetics would be preferred. And of course, patient preference. It all comes down to patient preference. That's what I've been learning in clinical practice. Even though there's something that might be number one for the patient, if they're not willing to do it, then it doesn't matter. And we want to work with the patient as much as possible. So even if we do have a younger patient, such as like 40 years old, but they're deathly afraid of warfarin, they are very, very busy, they don't have time for routine INR monitoring, making dosage adjustments all the time, which is required for mechanical valves, then in that case, we would give a younger patient a bioprosthetic heart valve. So we'll be talking about the ACCHA guidelines, and I also incorporated European guidelines as well, because as we'll see in a little bit, there are a lot of gaps even with our American guidelines. So as far as mechanical heart valves go, really it's class 1A recommendation to give warfarin. And of course, the INR goal is going to depend on the type of valve. If it's an older valve, such as like a ball and cage, those tend to be more higher risk for thrombogenicity. So their INR goal would be higher, like 2.5 to 3.5. Mitral versus aortic, mitral tend to have higher risk for thrombosis. So those patients would have a higher INR goal as well. And additional risk factors for thrombosis. If patients have some kind of hypercoagulable state, if they have cancer, as we all know about cancer-associated thrombosis, if they have AFib, of course, having higher risk for ischemic stroke, if they do have those additional risk factors for thromboembolism, then those patients would qualify for that higher INR goal of 2.5 to 3.5 versus 2 to 3, which is pretty standard. And of course, compared to just antiplatelet alone, or compared to no anticoagulation at all, warfarin does significantly reduce the risk of mechanical valve-related systemic embolism as well as valve thrombosis. So this is really class 1A, which is going to be different compared to bioprosthetic heart valve recommendations. So kind of shifting gears a bit, as you can see here, these are the package labels for DOACs. And each of the DOACs have a clear statement saying that they're only indicated for non-valvular atrial fibrillation. So what is non-valvular atrial fibrillation? There was a lot of confusion even among clinicians, cardiologists. There wasn't too much of a consensus there. So across the board in the literature, in clinical practice, there was a lot of discrepancies and confusion. So the American College of Cardiology, in addition to the American Heart Association, came up with a more precise definition to clarify what non-valvular atrial fibrillation means. So non-valvular AFib does not mean that the patient does not have valvular heart disease. So even if a patient has mild mitral stenosis and mild acute aortic regurgitation, aortic stenosis, those patients, it doesn't mean they don't have any of those conditions. What non-valvular atrial fibrillation means is AFib, in the absence, of mechanical heart valves, so no mechanical heart valves, and that means bioprosthetic valves are okay, right? As well as moderate or severe mitral stenosis, and it's because both these patient populations were all excluded from the key DOAC trials. And that's what that means by non-valvular atrial fibrillation. So we had mentioned previously that for patients with a mechanical valve, they have to be on anticoagulation, specifically warfarin. So why not DOACs? Well, the dabigatran manufacturers, they were sort of the pioneers here. And they conducted a phase 2 realigned study where they randomized patients with aortic valve replacement or mitral valve replacement to either dabigatran or warfarin in mechanical heart valves. And of course, the INR goal was dependent on patient-specific risk factors as well as the valve location. And only after 3 months, the study was halted prematurely due to a significantly higher risk of not only stroke, but also bleeding in the dabigatran arm compared to the warfarin arm. And therefore, we really do not have sufficient evidence to support DOAC use in patients with mechanical heart valves. And that sort of paved the way for the rest of the DOACs as well. So they were kind of the pioneers here. And this is for mechanical valves. So why are we seeing a higher stroke risk though? So we'll talk about the bleeding risk that we saw in a little bit when we're talking about edoxaban, but why are we seeing a higher stroke risk? Usually it's one or the other. So this is a potential theory for the mechanism of valve-related thrombosis. And it all comes down to pharmacology, right? What we talked about earlier. With warfarin inhibiting more, warfarin inhibits factors 2, 7, 9, 10, and protein C and S. And 7, as you might recall, is the tissue factor. And so warfarin, by inhibiting the tissue factor pathway, which dabigatran does not, as the direct thrombin inhibitor, it's outside of the tissue factor cascade. Perhaps that is why it's not adequate. Dabigatran might not be sufficient. So that is a possible theory here for valve-related thrombosis for dabigatran. Tissue factor here, and then again, DOACs being, except for dabigatran being 10A inhibitors, dabigatran being a 2 thrombin inhibitor, DTI. So here is a summary slide of mechanical valves. We mentioned dabigatran, right? We saw it was halted prematurely after 3 months. So we saw harm shown in the real-line trial. And the other 3 kind of followed suit. Even though they might not have a clear contraindication, like dabigatran, all the manufacturers do recommend that we avoid use in patients with mechanical valves. Rivaroxaban, there are a few very, very small studies, 7 to 10 patients, 1 arm, very short, on potential safety seen with rivaroxaban, but that's pretty much it. I was eagerly waiting for the REWA trial for rivaroxaban. It was a randomized study, but it got unfortunately terminated during the COVID pandemic, much like everything else that we've all experienced. And then as far as apixaban and edoxaban, we don't have any available data for mechanical valves. There is an ongoing study called PROACT 10A for apixaban, so we'll follow up on that and we'll see what the results for that look like. But as far as now, we don't have data for mechanical heart valves. Okay, so we talked about mechanical. What about bioprosthetic heart valves? Previously, we mentioned that bioprosthetic heart valves, they don't require anticoagulation. Generally, the only thing required is a single antiplatelet therapy. So ACCHA, this is 2021. These are most of the studies I'll talk about, and the guidelines are very new, very recent, mostly from either this year or last year. So these are the guidelines from this year. And as you can see, first of all, they're all class 2 recommendations, unlike class 1A with warfarin for mechanical valves. So in general, we don't have much data for bioprosthetic heart valves. But as far as antithrombotics go, ACCHA does say in patients who do not have an indication for anticoagulation, right? Do not have an indication for anticoagulation, such as AFib, which is very common. Those patients would only get baby aspirin, right? after TAVI, after SAVR, after whichever procedure that would allow them to get a bioprosthetic heart valve, they would only get one antiplatelet therapy, here specifically baby aspirin. And this is only in the absence of no other indications for anticoagulation. ACCHA does not talk about what happens if patients do have an indication for anticoagulation, which is why I've incorporated the European guidelines, which we'll talk about in a little bit. And as far as the other recommendations here, so baby aspirin is really the way to go. Initially, the first 3 to 6 months after a bioprosthetic heart valve, it is a foreign device, so there is somewhat of a risk for thrombogenicity. And to cover them during that period, ACCHA recommends either dual antiplatelet therapy or anticoagulation with warfarin, specifically INR 2 to 3, which is pretty standard. So there's either or there. And then as far as important concepts, again, indication for anticoagulation is what we need to look at first in terms of approaching bioprosthetic heart valves and the antithrombotic regimen. And then initially, again, the first 3 to 6 months, we have more flexibility. We can either give dual antiplatelet therapy or vitamin K antagonists such as warfarin, INR 2 to 3. And so we mentioned ACCHA, which is only talking about patients with no other indication for anticoagulation. What about European guidelines? I really like this algorithm because they break down into patients who do have an indication for anticoagulation versus patients who do not. So as you can see on the right here, if patients don't have an indication for anticoagulation, okay, this is going to sound very similar to the previous guidelines, ACCHA. Patients would only get one antiplatelet therapy, so single antiplatelet therapy, which is consistent with ACCHA recommendations. However, if patients do have an indication for anticoagulation, then what do we do? They also further break it down into patients with recent stent or not, because as you guys might recall, after a PCI or percutaneous coronary intervention is when patients get a stent, status post either MI or it could be elective for any kind of obstruction in the coronary arteries. After that, really they should be on dual antiplatelet therapy. As far as duration goes, all of that's kind of changing. Standard is 1 year, but we're trying to get, shorten the duration more and more. And there's more and more data saying we can shorten the duration. If we do have an indication for anticoagulation and we have a patient status post PCI or percutaneous coronary intervention, they should be on dual antiplatelet therapy. Right, but is that going to be in addition to the anticoagulation, or is that going to be just by itself? Well, if we don't have a PCI, then we would just continue the original oral anticoagulation, which is what I have here, instead of the antiplatelet. Okay, and unlike ACCHA, which only talks about warfarin, for bioprosthetics, European guidelines actually also include DOACs as being an option as well. And then we mentioned the PCI, the percutaneous coronary intervention. If patients do have a stent, historically we would give a patient dual antiplatelet therapy after a stent for 1 year. And if they already had AFib at baseline and they were on, for example, dabigatran or edoxaban, rivaroxaban, then we would add that in addition to the oral anticoagulation, and this is traditionally called triple antithrombotic therapy. There's a lot of controversy with that. So we don't want to do triple therapy here. We want to do a DOAC-based dual therapy because we'll talk about the harms later, but there's just excess bleeding and possible mortality associated with triple therapy. And so we want to give the DOAC-based dual therapy regimen for the shortest duration possible. Here it's listed as 6 months being the max. So we mentioned the algorithm, so let's get into the studies now. So we have DOACs, we have the 4 DOAC major trials, and we'll go through each one. And that's pretty much all the data we have as far as bioprosthetics go. But we'll go into each one here. So Aristotle, right, was the major trial that led to the approval of apixaban in the setting of non-valvular atrial fibrillation. And of course, because of the harms that we saw with dabigatran in the REALIGN study, of course, the apixaban manufacturers for Aristotle, and rightfully so, eliminated anyone with mechanical valves as well as clinically significant mitral stenosis. and of course any recent valves as well. And so that means that anybody with bioprosthetic heart valves were included because they didn't meet those exclusion criteria. And so in the original trial, there were 82 patients with bioprosthetic heart valves. And so there was a subgroup analysis or post-hoc analysis specifically looking at this population of patients with bioprosthetic heart valves and AFib. And of course, the baseline characteristics, they were not adjusted for differences. This was a post-hoc analysis. So there were some differences there, and there were few events. However, there were, as you can see in the table, there's really no statistically significant differences. So based on this, perhaps apixaban may be okay for patients with AFib who were on the apixaban for AFib and then they got a TAVI. This is we're gonna follow a similar pattern for the other ones as well as some caveats. Engage AF TIMI 48, this is the major trial that led to the approval of edoxaban in the setting of non-valvular atrial fibrillation. And so similarly, the original trial had excluded patients with mechanical valves, moderate to severe MS, recent valve implantation, meaning that some patients did have bioprosthetic heart valves. In this subgroup analysis, they kind of combined all valvular heart disease patients versus those without valvular disease. And as you can see, only about 7% of the patients with valvular disease actually had bioprosthetic heart valves in place. And this was a very small analysis of around 191 patients. And there was, as you can see, based on the 95% confidence interval, there's really no difference. There appears to be similar efficacy and safety between edoxaban and warfarin. So based on this, we thought edoxaban may be okay for patients with bioprosthetic heart valves and AFib if they were already on it at baseline. But just a few months ago, there was a study that might change all of that. So the Envisage TAVI AFib trial. This was a prospective, multi-center, randomized, open-label, non-inferiority study, specifically looking at patients with pre-existing AFib. So AFib at baseline, concurrent indication for anticoagulation, edoxaban versus warfarin, and these were all TAVI patients. Mean age being 82, which is, and that's kind of what we're looking for, right? Because TAVI patients tend to be a little bit older. About half did have concomitant antiplatelets. TTR, or time in therapeutic range, is basically, I don't know how familiar everyone is, but it's a measure of looking at the effectiveness of warfarin in clinical trials. So in clinical trials, if patients had constantly INR 1.2, 1.3, 1.4, that's all subtherapeutic, which would be an unfair comparison compared to apixaban or edoxaban. So we want to look at the time in therapeutic range. Usually for clinical trials, we shoot for over 60%. So that would be an acceptable TTR. And what they found was non-inferior primary efficacy to net adverse clinical outcome ratio. However, what they found was a significantly higher rate of major bleeding in the edoxaban group for TAVI patients with AFib compared to warfarin, especially GI bleeding, as you can see here, which is very shocking for everybody. So as DOAC-induced GI bleeding, that might be a common phrase that you guys might have heard. So GI bleeding rates have shown to be common for the DOACs generally, except for apixaban. So edoxaban, rivaroxaban, dabigatran. And the actual pathophysiology is unclear. So all of this is kind of theoretical. And there may be some possible associations with absorption. So warfarin has almost complete absorption, almost 95%. And the remaining has no anticoagulant activity in the GI system. All of that is in contrast to the DOACs that we'll talk about. Dabigatran, remember, it's a prodrug. Only 6% is bioavailable. And the remaining does traverse through the GI system. So there's this theory that potentially the remaining drug can have topical anticoagulant effects, thereby causing GI bleeding. Similar idea for rivaroxaban. Rivaroxaban has better bioavailability, but some of it is excreted as unchanged in the feces. So there may be some potential direct topical anticoagulant effects from rivaroxaban as well as edoxaban. So the three, except for apixaban, has not shown to have significantly higher rates of GI bleeding. And another theory is the dosing regimen. So rivaroxaban, remember, we're giving a big dose, 15 or 20 for AFib stroke prevention once daily. So potentially by giving a bigger dose, there's higher peak concentrations, and that can cause more GI bleeding that way. But remember, dabigatran is BID. So, and dabigatran has shown to have higher GI bleeding risk compared to warfarin. So that theory might not hold true for all, in general terms, but these are all theories. So we mentioned edoxaban, remember, with the higher GI bleeding risk in TAVI patients with AFib. Moving on to rivaroxaban, right? So the ROCKET-AF trial was the major trial that led to the approval of rivaroxaban in non-valvular atrial fibrillation compared to warfarin. This one actually excluded all prosthetic valves, so including bioprosthetics. So we don't have any data from the major clinical trial there. We do have a River 2020 trial, which just came out last year. It was an open label randomized controlled trial in patients with baseline AFib as well as bioprosthetic mitral valve, comparing rivaroxaban to warfarin. And at 1 year, they found similar efficacy and safety outcomes. But this is the caveat here. What do we say about TAVI patients? As you might recall, we mentioned that TAVI patients tend to be a lot older because they might not tolerate the anticoagulation required with mechanical heart valves. So our TAVI patient population is generally older. But this trial, as you can see, the mean age is significantly younger. And we don't have much safety efficacy data for our older patient population, which is the most common in our TAVI population. And of course, it's open label, so limitations there, as well as this is bioprosthetic mitral valve. And so we can't really, we cannot extrapolate those same findings to bioprosthetic aortic valves. TTR, again, that's pretty acceptable, 60% time in therapeutic range, so a fair comparison of warfarin. And loss of follow-up is almost complete, so that's also acceptable as well. So rivaroxaban, based on this, sure, we might have a little bit of safety efficacy data for bioprosthetic heart valves in AFib patients, but the caveat is in our younger population. And then moving on to dabigatran, remember they were the pioneers, sort of, with the mechanical valves, and they saw harm, halted prematurely after 3 months for mechanical. What about for bioprosthetic heart valves? The RELY trial for AFib excluded prosthetic heart valves because, of course, they saw the harm associated with excess bleeding and excess stroke in the REALIGN study. DAWA was from the dabigatran manufacturers, and this is a phase 2 prospective open-label randomized study, randomized to dabigatran or warfarin for either mitral or aortic bioprosthetic heart valve. And it was unfortunately terminated prematurely after 3 months. And potentially what I think is the providers and patients were a little bit nervous based on the previous findings that we saw with dabigatran causing more stroke and bleeding compared to warfarin. And so there may be some concern there, but in general, we don't have much data for dabigatran either. So in summary, for bioprosthetic TAVI patients with a concurrent indication for anticoagulation, right, such as AFib, really the only one that we have safety data for, it looks like, is apixaban, based on that post hoc analysis of Aristotle, which is, again, limitations there, and rivaroxaban, potentially in our younger patient population. But as far as edoxaban and dabigatran, we don't have sufficient safety efficacy data. And then these two next studies are going to be kind of like combining DOACs versus warfarin. So this was in Japan. It was an observational propensity score matched registry study of all DOACs compared to warfarin in TAVI patients with AFib. So patients, about half had, a little over half were on DOACs, and they didn't stratify based on the type of DOAC, so we don't know specifically. Mean age, acceptable, and there were some statistically significant differences there. And so therefore, the authors conducted the propensity score matching. So after adjusting for those baseline differences, the DOAC group did have a lower rate of mortality compared to warfarin. And there were similar rates of bleeding and stroke, but there's any significant limitations to note. Remember, we talked about INR and how in order to assess for the effectiveness of warfarin, in order for it to be a fair comparison, the INRs have to be therapeutic. But this was a registry study, so we don't have the INRs in that kind of data. And of course, this is Japan, so we can't extrapolate the same findings to here at the United States. And anytime we use registry data, there might be some coding inaccuracies, so that's a limitation there. And of course, we need confirmation from larger randomized prospective trials. And as you can see, the all-cause mortality was significantly lower for the DOAC group. This is a similar study in France where they kind of combined all the DOACs compared to warfarin for TAVI patients who already have an indication for anticoagulation, such as AFib. So again, this was a prospective observational study of the French National Health Claims Database, propensity score matched to adjust for those baseline differences. And a little less than a quarter were on DOACs, the rest were on warfarin. Mean age was acceptable. And after adjusting for the differences, at 3 years, there again was a significant reduction in mortality and major bleeding here for DOACs compared to warfarin. Similar rates of stroke and acute coronary syndrome, but again, similar to the previous study, this one also didn't incorporate INRs, so we don't know how effective the warfarins were, the warfarin therapy was, and because this was in France, we can't extrapolate it to our patient population here in the United States. And again, there might be some coding inaccuracies just because of the nature of the design of the study. And there may be some, even despite adjusting for the baseline differences, of course, as we all know, there may be some residual confounding that might exist. And then so for indication for anticoagulation, we mentioned this is why in any patients who do already have a baseline indication for anticoagulation, such as AFib, then we would just resume that original anticoagulant, such as apixaban or edoxaban, rivaroxaban, dabigatran. And if they do get a percutaneous coronary intervention, we give the DOAC in addition to the antiplatelet only for the shortest time period possible, max being 6 months, and then resume oral anticoagulation thereafter for that AFib. So why do we not want to add antiplatelets? We mentioned here on the right side, we said single antiplatelet therapy only, right? And then on the, indication for anticoagulation, only oral anticoagulation therapy only. So why do we not want to add on an antiplatelet? So Popular TAVI, this came out just last year. And what they did was for AFib patients with TAVI, they randomized to clopidogrel and an anticoagulant, either warfarin or DOAC, compared to anticoagulant alone. And then CAD, MI, the rates are listed there for you, basically to show that we don't know definitively who would have qualified for that additional antiplatelet therapy because we don't have information on the PCI or percutaneous coronary intervention. And what they found was compared to the antiplatelet therapy and anticoagulant group, the anticoagulant alone had lower bleeding, of course, because they were not getting that additional antithrombotic. And it was at the expense of similar rates of stroke and mortality. So this is why we don't want to add on an additional antiplatelet therapy, especially in patients who don't qualify, who didn't have a recent PCI. And it's unclear, again, who would have qualified for that dual antiplatelet therapy based on their history of recent PCI or percutaneous coronary intervention. And then this one is basically goes to show, the study by Kuno and colleagues goes to show that this is why we don't do triple antithrombotic therapy in our TAVI patients. So this was a meta-analysis, of course, with mostly observational studies, and there was an association for higher mortality in patients receiving triple antithrombotics in TAVI patients. Also a higher risk of bleeding, but no difference in stroke. And of course, it's really unclear who had PCI, who had recent intervention, who would have qualified for dual antiplatelet therapy. But this kind of goes to show that we want to shy away from using triple antithrombotics because of that excess bleeding and possible mortality associated with triple antithrombotics. So what about for patients without an indication for anticoagulation? We said those patients without AFib, only TAVI, they would qualify for single antiplatelet therapy only, right? So what exactly is the evidence for DOACs, right? So can we add apixaban for patients without AFib who got TAVI, or dabigatran or edoxaban, status post TAVI, no additional risk for VTE, AFib, no history of stroke, etc. So can we just add on a DOAC? And so Galileo, this came out just last year. It was rivaroxaban after TAVI, randomized open label study without an indication for anticoagulation. So no AFib at baseline, no recent history of PCI or percutaneous coronary intervention, acceptable mean age, because remember TAVI patients tend to be a little bit older, and what they found was compared to low dose rivaroxaban and aspirin combined, and then rivaroxaban thereafter, comparing that group to standard, which is dual antiplatelet therapy, and then aspirin thereafter. It was actually terminated prematurely after 17 months, and what they found was that in the rivaroxaban group, so patients without underlying AFib, recent PCI, by adding on that rivaroxaban and continuing rivaroxaban monotherapy thereafter, there was a higher risk of death, thromboembolism, and risk of bleeding, as you can see here. So this is why we don't give rivaroxaban status post TAVI in patients without AFib, without a history of VTE, without additional thromboembolism risk factors. Apixaban, this just came out earlier this year, Atlantis. It was an open-label randomized phase 3 superiority study stratifying patients into patients who have an indication for anticoagulation versus those who do not. Further stratified into standard of care versus apixaban for each stratum. And of course, any recent PCI, all of that was excluded, and the mean age acceptable. And what they found is that at 1 year there was no superiority. No superiority, as you can see here, based on the 95% confidence interval. But what they found was in stratum 2, which is, remember, the right side, patients who didn't have a concurrent indication for anticoagulation, what they found was versus standard of care, right, which is antiplatelet, either single antiplatelet therapy or dual if they had a recent PCI. So standard of care compared to apixaban, there was a significantly higher rate of non-cardiovascular death for apixaban. So the reasons for that are, it's listed here for you, sepsis or end-stage renal failure. And the authors did want to mention that it's something worth mentioning because it's a little bit unexpected. It was very shocking for everyone, and it's it's clinically relevant. So in summary, for TAVI patients who do not have a concurrent indication for anticoagulation, remember we saw the harm associated for rivaroxaban in our Galileo study, possible harm for apixaban, right, with the increase in non-cardiovascular death. Edoxaban, we really don't have much data. I listed a study here for you, but they combined patients who did have an indication for anticoagulation and those who didn't. So that's listed there for you. And dabigatran, we don't have any data. So in conclusion, the drug of choice really is warfarin for mechanical heart valves. Again, INR goal is going to depend on patient-specific risk factors, such as the valve location and additional risk factors for thromboembolism. On-X aortic is FDA approved for lower INR goal for mechanical valves. And we can add as aspirin, we can, it's an option, but of course we have to accept the bleeding risk associated with it. As far as bioprosthetic, it's going to further divide into patients who do have a concurrent indication for anticoagulation versus those who do not. Ultimately, again, if they do already have an indication, basically we keep them on that single anticoagulant that they were on previously. We don't need to add on anything else based on that popular TAVI study that we saw with the antiplatelet therapy. Unless they do have a PCI, then we give that DOAC-based dual for the shortest duration possible and then resume the anticoag thereafter. And we do want to avoid triple therapy because of possible associations with mortality. What about patients without a concurrent indication for anticoagulation? We said single antiplatelet therapy really is the way to go. Initially, we might have a few options, first 3 to 6 months being dual antiplatelet therapy or warfarin 2 to 3 INR goal. And the next 2 studies are going to be basically what's happening in real life, though. So we do have the data, limited data, but what's actually happening in real life. So this is our registry data for all TAVI patients here in the United States. So from 2011 to 2015, patients with AFib, the baseline characteristics are listed here for you. And compared to, and patients did happen to have triple therapy, and there was really no difference in mortality and stroke. Of course, adding that additional anticoagulant led to worse outcomes. And of course, given the limitations with the study, and there was really no difference in mortality, but higher risk of bleeding, is what this is saying. And so there's significant heterogeneity. Remember, we mentioned the harms associated with triple therapy, but a lot of patients do get put on triple therapy, as you can see here. Lastly, this is a study on the same database, but specifically looking at surgical patients, either as bioprosthetic or mechanical. And they were further stratified into DOAC versus warfarin. The baseline characteristics are listed here for you. And what we found was an increasing trend, right, of patients being discharged on DOACs after bioprosthetic heart valves. And we talked about all the limitations, all the limited studies. We don't have, it's mostly based on post hoc analyses of major studies, few studies here and there, but we don't have adequate data to support efficacy and safety. Mechanical valves, again, it's a direct contraindication specifically for dabigatran. The other ones avoid use, but we do have 1% of patients being discharged on DOACs for mechanical valves. And despite inadequate evidence, we really don't have the long-term clinical data. Lastly, this is my last slide, there's really no role for DOACs for mechanical valves. For bioprosthetics, on the other hand, we need to first consider if patients do have an indication for anticoagulation. Otherwise, we don't need to add on anything. Versus DOACs versus vitamin K antagonists, there's really no head-to-head comparison. We don't really know. And the use of DOACs is increasing despite lack of sufficient evidence. And there's, again, limited direct comparisons between the antithrombotic regimens, so we have to make a patient-specific decision based on their risk factors. And due to lack of robust randomized clinical trials, we must remain cautious about DOAC use in the setting of bioprosthetic heart valves and, of course, mechanical heart valves. And that brings us to the end of the presentation. Valvular heart disease, number one, we said rheumatic disease, right? Because we're here fortunate enough to be able to adequately treat streptococcal infections. Differences between mechanical versus bioprosthetic, number one thing to consider is risk of bleeding, right? Because for mechanical, we require anticoagulation specifically with warfarin. Mechanism, remember warfarin being 27910, but DOACs is just 10A or a DTI, thrombin inhibitor. Lastly, I know it looks lengthy, but in short, it's a patient case. Elderly patient, status post TAVI, have baseline AFib, on-home apixaban. What do we do? Do we switch the apixaban to warfarin? Do we reduce the dose? By the way, the age, weight, and creatinine for apixaban dosage adjustment is there for you. Do we reduce it? Oh, I keep doing that. I'm getting a little bit nervous about the time. I'm sorry, Dr. Kudo. Or do we, in addition to the apixaban, do we start a dual antiplatelet therapy? So the answer to this is continue as is, continue current medications. That's all the data that we have so far. And these are my references. Thank you so much, everyone, for your time.
You did a great job.
Thank you so much, Dr. Kudo.
Thank you very much, Dr. Ryu. What an amazing amount of information she has stored up there. All of you are waiting for the session code. The session code for today's session is 401302. I'll repeat it, 401302, and there it is, amazingly enough, by magic, there it is. So please jot that down, and please join me once again in thanking Dr. Ryu for a very, very comprehensive presentation. Good job.
Thank you so much.